All right. Good evening to everyone, and thank you so much for inviting me because as one of the speakers for this month's PAO. And yes, I'm gonna begin. I have no financial disclosures, and this will be the outline of my talk for tonight. It will begin with a review of the angle anatomy, straight into gonioscopy, which will be interspersed with a few cases for us to better understand how valuable gonioscopy is in the treatment of glaucoma, talk about some variations in the appearance of the angle, and after that, I'll discuss some new diagnostic tools that are gaining some traction in the practice of glaucoma. So just very quickly, this is the definition of glaucoma, which we know very well. It's a group of neuropathies associated with structural changes at the optic nerve, causing field changes and blindness. Notice how the definition does not include any description of the angles or intraocular pressure. And I've always found this just a bit peculiar considering how much of our glaucoma treatment is focused with addressing the angles. In fact, the angles are so crucial to the management of glaucoma because often the initial treatment is what dictates the status of the angle, is dictated by the status of the angles. So here we have two broad categories, right? We have the angle closure patients and the open angle patients. Angle closure glaucoma, we have an obstruction of the angles, and usually your initial approach would be to reverse this angle obstruction, whereas in your open angle, it's your intent is to improve flow, usually with laser treatment or medical treatment. Accurate gonioscopy allows us to differentiate between an open and a closed angle, which ultimately determines the type of treatment. Conversely, inaccurate interpretation of the gonioscopic findings may lead to improper management. So for today's session, I will be breaking down the process to make this very intimidating task simple enough for everybody. Mastery of the angle anatomy is essential before even attempting to perform gonioscopy. The visualization of the anatomic landmarks marks the fine line between an open and a closed angle. Here is a frontal view of the angle with as much as 5 prominent anatomic landmarks visible on gonioscopy. The most anterior of these landmarks is the Schwalbe's line, which is the termination of the corneal Descemet membrane. Adjacent to it is the trabecular meshwork, a circular spongework of connective tissue where aqueous humor drains through, and majority of the drainage occurs in the more posterior half of the meshwork, or the PTM. Posterior to this is the scleral spur, a protrusion of the sclera into the anterior chamber. And more posterior to that is the ciliary body band, which marks the anterior end of the ciliary muscle. Though not immediately visible on gonioscopy, knowledge of adjacent anatomic structures and their relationship to the anatomic landmarks are important in understanding the pathologic variations in the appearance of the angle. So here's a cross-sectional view of the angle structures, which visualize structures on frontal view of the angle. So you have the Schlemm's canal. This is where it's adjacent to the trabecular meshwork. It's where aqueous drains before draining to the collector veins. Then you have the longitudinal ciliary muscles that are attached to the scleral spur. Because of their attachment, the collection of ciliary muscles contribute to aqueous flow regulation. It also regulates lens accommodation. The ciliary processes are radial folds where lens zonules attach to, suspending the lens, and the space between the iris and the ciliary processes is the sulcus. Again, these are the 5 structures that you can usually see. Now let's look at the frontal view of the angle as seen through gonioscopy. It can be confusing at first, but always just refer back to the anatomic landmarks of the angle. It's the ciliary body band, the scleral spur, the trabecular meshwork, and the Schwalbe's line. The Schwalbe's line is sometimes slightly pigmented. If you have difficulty identifying this layer, one can use the parallelepiped method of illumination by using a narrow slit beam and seeing where the linear reflection of the cornea and reflection of the sclera meet. So once again, familiarize yourself with the relative relationship of the angle anatomic landmarks. Also note the alternating appearance of pigmentation across the landmarks. Pigmentation can be used as a relative guide in identifying such landmarks. I think of it as a cake, or you can even think of it as an Oreo with layers of chocolate cake and vanilla icing. So notice that your ciliary body band, it's pretty dark. It's almost like this dark brown color. And then the scleral spur, it's very white. Next to it is the darkly pigmented with the light brown trabecular meshwork. And then the anterior trabecular meshwork, which is lighter pigmentation than your Schwabi's line. So it's always this alternation or this alternating layers of dark, light, dark, light, dark, light. When you see all the layers, if you see all the layers of the cake, your angles are most likely open. If you only see a few layers or you don't see any layers at all, then your angles are likely to be closed. Now that we know what to look for, let's go through the methods that we can go through in examining the angle. So first is gonioscopy. Under normal conditions, light reflected from the angle structures undergoes total internal reflection at the tear-air interface, and light is reflected back into the corneal stroma. This prevents visualization of the angle structures. Gonioscopy lenses eliminate this tear-air interface by contact of the plastic or glass surface on the surface of the eye, allowing visualization of the angle. Gonioscopy can either be direct or indirect. Direct gonioscopy is called direct because the light reflected from the angle is directly visualized. It is performed using an OR or handheld binocular microscope with the patient supine. Shown in this photo is how a clinic diagnostic procedure is performed with a patient supine and with a doctor using a handheld biomicroscope. So examination can be done alternately on both eyes with the two lenses. So in this image, you see that both lenses are placed on the eye, and then it's the physician moving around the lens, going through the different angles and clock hours with both lenses placed on the patient. Direct gonioscopy lenses include first the Kepi lens. So this is the prototype diagnostic lens, and it allows view into the angle over a convex iris without distortion. The viewer can maneuver around the lens to view open angle structures which may initially appear close. So sometimes it may appear close, but really the angles are open. It's just that it's steep. So the way that the physician goes about this is that they would tilt the microscope or tilt their view and go around the patient. Here's another example. This is the Barkan lens. It is a surgical gonio lens, and noted the blunted side on one end. And this blunted side allows space for you to perform goniotomy in the operating room table. A similar lens, a surgical gonio lens as well, is the Swan-Jacob lens. This time, the modification here is that there is a handle. So this is a lens that can be used for goniosyncytialis, for example. So what are the relative pros of direct gonioscopy? The good thing is that it has a panoramic view because you're seeing a number of clock hours with one view. You can allow simultaneous examination, meaning you can have both lenses on the patient, and if you have to compare one clock hour to another clock hour, you can just shift your position. You don't need any viscous coupling agents. Tears are enough. And probably the biggest pro is that you can use this for surgery. One downside to it, though, is that you cannot necessarily perform indentation on some lenses, especially those that are large diameter. Also, your magnification is only limited by your handheld microscope. You have good magnification if you're using it in the operating room, but if you're also only using a handheld microscope, it's limited by the magnification of that microscope. And because you have two lenses on the patient and you have your own handheld biomicroscope, sometimes you might require assistance to use these lenses. In contrast, the indirect gonioscopic lenses view an angle which has already been reflected from the mirror, hence the name indirect gonioscopy. So the viewer sees an inverted image. It is viewed through a slit lamp biomicroscope, and thus it allows examination of the patient upright in the clinics. The Goldman 3-mirror gonioscope is a popular lens, especially for beginners, because of its ease of use. It's used to examine the angles and also for laser trabeculoplasty, gonioplasty, and examination of the peripheral retina and stereoscopic view of the nerve head. So it's very versatile. That makes it popular. Its use requires a methyl cellulose coupler, a coupling agent like your viscoelastic gel sometimes, and because of the large lens diameter, it does not allow indentation. So you see in the image on the right, the diameter of this lens is much larger than the diameter of your cornea. So it's indentation gonioscopy is not possible. So this type of lens has three lenses. First, you have the parabolic lens, which reflects the light at a 59-degree angle and allows you to view the angles. Then you have your rectangular lens reflecting light at a 67-degree angle, giving you view of the iris and the lens. Then there's your trapezoidal mirror, reflecting light at a 73-degree angle, allowing view of the peripheral retina and your ciliary body. And there's a central lens that allows you to view the posterior pole. So illustrated here is how the gonio lens reflects an inverted image. In this illustration, with a parabolic lens placed superiorly, we are viewing the inferior angle. The image is inverted, but not reversed horizontally. We are merely getting a mirror image. We'll go through some exercises in a bit to get us used to this configuration. The Zeiss 4-mirror gonio lens allows for minimal lens rotation since it has 4 mirrors reflecting all 4 quadrants. Tears may serve as the coupler, and because of its small contact diameter, smaller than the corneal surface, it allows for indentation gonioscopy. This is similar to the Posner 4-mirror lens, which is more readily available in the market. It also only needs tears as a coupling agent with topical anesthesia. Because it allows for indentation, you can determine if an angle is appositionally or synically closed. So, remember that images viewed with an indirect gonioscopic lens are mirror images. In this example, viewing the inferior lens, we are actually seeing the superior angle. So do not confuse this configuration with 1 o'clock on the right and 11 o'clock on the left with this. So in this image, this interpretation is false, right? So for example, this is the right eye. This is the correct interpretation. It's 11 to your left, 12 below, 1 to your right. It's not this. So you're not reversing it horizontally. Similarly, similarly, it applies to the lateral lenses. So here, this is the patient's left eye. You're putting the lens on the left eye. You're viewing you're looking at the mirror nasally. So this is actually showing you the angles at the 2nd clock hour, the 3rd clock hour, and the 4th clock hour temporally. Just mirror image. So what are the relative pros of indirect gonioscopy? Again, some lenses will not require you to use a viscous coupler, so it's a bit more convenient for the patient. Variable magnification is possible because your slit lamp is very versatile. There's versatile magnification and illumination there. You can also use a corneal wedge to view some of these structures. And probably the most beneficial is that you can perform indentation gonioscopy to differentiate synechial closure. A relative con for some is that because of the mirror view configuration, it can be confusing at the beginning. And because you are able to indent, sometimes there is inadvertent angle opening from indentation. So sometimes you can have falsely open angles because of your indentation. So because of the tricky sense or the tricky manner of this, some might find indirect gonioscopy a bit more difficult to learn. So these are comparisons of the two modes of examination. We see highlighted in yellow their relative strengths, some might think. So for direct, it's very panoramic. You can do simultaneous or alternating examinations, no coupler needed. There's no inversion of the image, and you can perform it at the OR. But for indirect, you can perform it with a patient very conveniently upright in the clinic, and you allow for indentation. So, what are some scenarios where you'd choose one over the other? If you are at the clinic, the indirect lens is definitely a bit more convenient. If you need a lens for surgery, the surgical lens is definitely more it's better. You have better view, and it's gives you better access with the angles. If you're a beginner, I'd still think that the indirect gonioscopy is a bit more convenient, especially with the use of the Goldman 3-mirror gonioscopic lens. And if you're suspecting angle closure, the benefit of being able to perform indentation with indirect gonioscopy makes it a preferred modality for gonioscopy. Now let's go to the very specific technique of how to perform gonioscopy. So regardless of which modality you choose to examine your patients with, the following are some general reminders which one must be conscious of during the course of examination. First, make sure that the patient is comfortably positioned. The examination might take anywhere from a minute to even 2 to 3 minutes, depending on the structures. So make sure that the patient can tolerate the position for the duration of your gonioscopic exam. Always take the IOP before gonioscopy, because gonioscopy changes the structures and the dynamics of your anterior chamber and might also affect your intraocular pressure. So before starting, apply your anesthetic. Make sure the room is dimly lit. A very bright room might inadvertently open your angles. A very dark room might inadvertently close your angles. Again, for the light beam, make it thin and short as not to falsely open your angles, and use a high magnification so you can see the structures very well. If you're using a Goldman 3-mirror lens, use a methyl cellulose coupling agent. Use the parabola-shaped gonio mirror pointed here in red. Use a high-power biomicroscope. And if you have to, or if you want to, although you can't indent, you can have dynamic views by having the patient gaze at different directions. So for example, you're looking at the inferior angle with the lens placed superiorly. If you wish to sort of see past the very steep peripheral iris, you might want to ask the patient to look up or towards the lens. So that's one of the variations or methods for dynamic gonioscopy for a Goldman 3-mirror lens. If you are using a Zeiss Type 4 mirror lens, you don't really need much. You don't need any methyl cellulose coupler. All you need is to anesthetize the eye. Again, the diameter is smaller than the cornea, and the radius of curvature is greater than the cornea. So this allows you for indentation gonioscopy to differentiate appositional and synechial closure. So let's just circle back. Why is this possible with indentation? So here we have on your left, an angle seemed to be closed because you're not indenting the eye. So notice how the peripheral iris is adjacent or occluding the trabecular meshwork marked by your Schlem's canal and the angles. If you indent, indentation allows displacement of the aqueous into the anterior chamber towards the angle chamber. So appositional closure will be opened with indentation. So notice here with indentation, the aqueous moves peripherally since there's no synechia, hindi siya nakadikit, it will still be able to open the angles. This is in contrast to an angle that is already synechically closed. So again, without indentation that's closed, if you indent on your cornea, displacing aqueous peripherally, if there's already synechial closure, nakadikit na siya, even if aqueous moves to the periphery, your angles will remain closed. So this is how you know it's synechically closed. So here's a photograph comparing the appearance of an angle before and after indentation gonioscopy. So the photo on the left shows the angle is very narrow. It's really technically closed with only the ATM visible. But notice that on the photo on the right with indentation, you can see multiple layers now. So let's circle back to the cake or the Oreo. So on the image on the right, you see this like light brown, then there's white, and there's the dark brown color. So that's the CBB. So it went from a closed angle to to an open angle on your right. So this means that this angle is closed, but only appositionally. So here's just a video to illustrate that. Hopefully you are able to see it. So in this situation, now we already have opening of the angles with indentation. So you notice the different layers. So here, indentation is backed off a bit. Sorry, it's a bit blurred there, but with indentation again, you're able to see again the different layers. So now we're seeing the SS with a bit more pressure. You're now seeing the ciliary body band. Now, a variety of gonioscopic grading systems have been developed, all of which aim to facilitate standardized description of the angle structures and abbreviate the description. The most commonly used gonioscopic grading systems are the Shea, Schaefer, and Spaeth systems. And although these are commonly used, no one system is an international or local standard. Keep in mind that each system is simplified, and it's always better to supplement the grading with descriptions for localized findings such as neovascularizations, angle recession of synechiae, and we'll go through these variations a bit later. So this is an example of the Shea classification. So in the Shea classification, the lower grade means it's very wide open. So if the wide open with all the structures visible, you see all the pigmented layers, you see the cake that I call, and then as your grade increases, you see less and less or fewer layers, with grade 4 being totally closed. You can only see the Schwalbe's line. The Schaefer system describes the angle between the trabecular meshwork and the iris. So this is a graphic representation of that. So although it describes degrees, the grading is also associated with descriptions like being extremely narrow, narrow, open, or wide open, and it also describes which structures you can look for. So as opposed to the Shea classification, with the Schaefer, the higher your grade, the more open your angles are. So baliktad siya. Then the Spaeth gonioscopic grading system expands the system to include a description of the peripheral iris contour, the insertion of the iris root, and the effects of dynamic gonioscopy. So, for example, on your upper left, note the insertion of the iris root. There's a description for that. So you grade it A, B, C, or D, A, B, C, D, or E, depending on where the peripheral iris inserts into your into the angle. And then you have a description of the angle width. There's also a description of the configuration of the iris. Is it very steep? Is it just regular? Or is it concave? Or is there a plateau configuration? Noted by the image in yellow below, and we'll get to that a bit later. So let's start with a case to better appreciate gonioscopy and how it affects treatment. So for example, in a patient, a 54-year-old female with blurring of vision of the right eye with 1 year 1 year history of blurring of vision of both eyes described as cloudy but otherwise asymptomatic, no pain, redness, or halo. Visual acuity is as shown here. Pupils are briskly active with no RAPD, pressures are normal, and the patient is hyperopic. Notice a shallow anterior chamber with a convex iris plane, and notice that the peripheral chamber is also very shallow. You examine the nerve, it's only mild cupping. On gonioscopy of the right eye, again, the lens is superior. So we are actually looking at the inferior angles. This is closed. I don't see any angle structures. I don't see a cake. I don't see no layers. It's closed. But on indentation, adding a bit of pressure, you now see an open angle. You see many pigmented layers. You see the scleral spur and the ciliary body band. So now you see the different pigmented layers here. Now we're looking again. The mirror is temporal, which means you're looking at the nasal angle. We're looking at clock hours 2 to 5. Notice here that we have a bit of APM at the second clock hour. Otherwise, it's still closed past that. With indentation, it opens to CBB. Hopefully, you're able to see it, but there's a very faint light pigmentation alternating with a bright white pigmentation. Then there is a dark brown pigmentation. That's the CBB. It means it's open. So this is with the right eye, your lens is on the nasal side. You're now visualizing the temporal angle. Notice again how there is only APM visible. With indentation, you're able to see more pigmented layers. So this is open. And this is just a diagrammatic representation of your findings. It's always important to record your gonioscopic findings. So before and after indentation. So without indentation, it's closed on all quadrants. With indentation, you have to describe, or you can also note down with as much detail as you want, how open that angle is. So it's open, but how open? So you can also write CBB. So in this patient, because it's closed initially, there is iridotrabecular contact because once you indent, it's open. There's no synechia. So it's only 180 more than 180 degrees of iridotrabecular contact. And it's very important that you also recall your ISGEO classification and diagnosis of what defines an open or closed angle. So in that previous case, we have a situation where there's closed angles for more than 180 degrees before indentation, but the IOP is normal, there's no synechia, and there's no apparent neuropathy, which means that this patient is only a primary angle closure suspect. And for these instances, for PACS, it's acceptable to observe annually, especially if there are no relative or absolute contraindications. Because of this, we can observe. But if the patient has certain relative indications, ELA is a treatment option, especially for patients who need frequent dilation, episodes of previous attack, or in those with difficulty with follow-ups. So I hope you appreciate how the gonioscopy was able to clearly determine our plan of treatment. If gonioscopy was not performed, we wouldn't have known whether this patient had angle closure or open angles. We wouldn't have known if laser iridotomy would have been needed. If we just presumed that this was an open angle, we wouldn't have been able to provide the necessary laser iridotomy that this patient needed. So after iridotomy, notice how the angles have been opened up to CBB even without indentation. Superior angle and inferior angle. So now let us compare that previous case of an angle closure to this next case. Note how management is drastically different in this case of angle closure because of a variation in findings. So it's closed, but there's a variation, and we'll talk about it. So this is a 51-year-old male with blurring of vision in both eyes, with a 2-year history of blurring of vision, both eyes associated with headache and photophobia. So the persistence of blurring of vision prompted consult. The patient is also diabetic for more than 10 years and has been on insulin. Visual acuity on the right is 5/200, not improved on the left. It's counting fingers at 3 feet. So the pupil on the right eye is mid-dilated, just slowly reactive, with the left being briskly reactive, and there's RAPD of the right eye. Pressure is very high on the right, normal on the left, and the patient is only mildly hyperopic. So this is the slit lamp image of the right eye. Notice the mid-dilated pupil and the dense neovascularizations on the iris surface characterized by a haphazard course. The chamber remains deep, and one would think, if you didn't perform any gonioscopy, you'd think, oh, it's deep. It probably might be open. The left eye also appears normal at first glance, but on higher magnification, we see fine rubeosis already present in the pupillary border. So notice that there are light red flecks in the superior sector, even temporally and nasally. So again, the chamber is also deep. So you would think that it's probably an open angle. So this is a view of so you examine the nerve. The right eye has severe cupping. The left has poor view from vitreous hemorrhage. And you perform gonioscopy on the right eye. So this is the gonioscopic view of the inferior angle. Notice here that there are sectors where you see those multiple layers of your of the angle structures. Specifically here at the 5th clock hour, at around 5:30, Notice how you see CBB, scleral spur, PTM, and even Schwalbe's line. But very just adjacent to that, at the 6 o'clock hour, directly at 6 o'clock, notice that there is this angle closure, just like the peaking of your iris, and it's almost adherent to the angle structures. And then at the 7 o'clock hour, there's this very broad sheet of iris adherent to your angles. On indentation, the broadsheets are seen not to move. They're still there. They are persistent. And there's note of wispy webbed vascularizations over the angle. Similar findings were seen on the nasal angle. So there are still open angles at around the 1st and 2nd clock hour, but around the 3rd and 4th clock hour, you notice again the broadsheets of iris adherent to the angle. It also remains opposed even after indentation. So from what we know, this is already suggestive of synechia. Now we're looking at the superior angle again. Some angles are still open to CBB, but again, there is this apposition at around the 11th clock hour with some red tinge adjacent to it. With indentation, there is persistence of this sheet adherent to your angles. And there is a view of your temporal angles. Notice here that you have this pigmentation. There's this like hyperpigmented layer adjacent to the white scleral spur, and that would mean that it's open. You see the PTM and the SS. We don't really see the CBB. Upon further indentation, it doesn't open past SS. You don't really see the CBB. So though this is technically open, this might still also suggest that there might already be beginning low-lying synechia at the level of the CBB. So synechia typically starts creeping up. So it might start initially at your CBB, it proceeds to occlude SS, and eventually the PTM. So let's look at the left eye. The left eye seems to be very open. You see all the alternating pigmented layers. This is the temporal quadrant, the superior quadrant, and the nasal quadrant, all open. So despite having pockets of visible CBD in the right, there are still also extensive areas with synechia, which physically occludes the aqueous outflow through the trabecular meshwork. Hence, the diagnosis in this patient is a close type of glaucoma, secondary to neovascularizations. So this is an example of how I record the findings. But actually, in your chart, when you're using a pen and paper, you can even be more detailed than this. You can draw where the synechia is. You can draw the sheets, the broad sheets, which specific clock hours there is, which specific clock hours the angles are still open at. So unlike our first angle closure case, this is treated by treating the primary etiology of the angle closure, which is neovascularization. Hence, PRP can be ordered for both eyes. So what is synechia anyway? Well, synechia is a condition where the iris has become attached further forward into the angle than normal. Because of the mechanical obstruction, it can interfere with aqueous flow to a significant extent. Always remember that synechia is not found in uncomplicated primary open-angle glaucoma, pseudoexfoliation syndrome, or pigmentary glaucoma. PAS is typically a complication of many ocular conditions as well and may develop from various ways. So some causes include pupillary block. Pupillary block is still the most common cause, especially in cases of primary angle closure. It can be a sequela of laser trabeculoplasty. It can occur after persistent iris bombay, long-term intraocular inflammation, iridocorneal endothelial syndrome, as a complication of eye injury, prolonged anterior chamber shallowing, and, as we've seen from before, neovascularizations. In intraocular inflammation, acute iritis rarely causes synechia. Chronic iridocyclitis causes synechia, and synechia does not typically go past the Schwalbe's line. These are in instances of ICE and postoperative shallowing of the AC, iris bombay, NVG, and pupillary block. So freeing recently formed synechia can be of benefit sometimes. So in patients where we perform goniosynechiolysis, this is the intention. If there are just a few clock hours of synechia that hasn't been occurring for a long time, the hope is that with synechia goniosynechiolysis, opening of the angles can still resume or return the flow to your trabecular meshwork. So here we have synechial closure in 4 quadrants with neovascularizations. So our diagnosis is secondary angle closure from neovascular glaucoma. And because of that, PRP is the treatment. Since this patient has PDR with secondary neovascularizations already, you treat the underlying condition, which in this case is the diabetic retinopathy. So PRP might be needed, anti-VEGF might be needed, depending on how the pressure is controlled. You might want to start medications, and if it's persistently uncontrolled, surgery is already indicated. So notice how this approach was very different from our previous case, in that although both angles are closed, the direction of treatment was drastically varied because of the nuances in the finding in the angles. This time, let's discuss another case of angle closure wherein gonioscopy greatly dictated the definitive treatment of a patient. So in this 75-year-old male with a 20-year history of gradual blurring of vision of the right eye with eye pain, the patient eventually had vision loss of the right eye, and the left eye remained asymptomatic. So the patient came in just wanting to inquire regarding prognosis. So the vision on the right eye is already NLP. On the left, it still improves to 20/20. The right eye is already mid-dilated, non-reactive, while the left is still briskly reactive with the reverse REPD of the left. Pressure on the right is very high at 55. On the left, it's still normal. So this is a slit lamp examination of the right eye. So here, there is a very shallow central anterior chamber with a convex plane. This is the left eye with a relatively flat central anterior chamber, but the periphery is quite shallow. So notice that the periphery, it's shallow. When you move to the central anterior chamber, it's quite flat. So the right eye has no view from the dense cataract. The left, there's only mild cupping. So you perform gonioscopy of the left eye, and you notice that the inferior angle is closed, but on indentation opens to CBB. The temporal quadrant, there's some ATM visible. On indentation, it opens up to CBB. Nasally, it's closed again. On indentation, you notice it opens to CBB. And for the superior quadrant, it's again closed with opening to CBB. However, you note that there's this peculiarity once you indent. You notice that there's the appearance of these double humps in the iris contour. So this is the double hump sign, which is also known as the sigma sign because of the S shape. So the double hump sign or the sigma sign is determined by the ciliary processes that elevate the iris root, the lens curvature that supports the iris surface, and the space between them. So here, the indentation, without indentation, you notice that it's just convex, it's closed. Once you indent, there's the appearance of this concavity between these two humps. And this is a histologic view of what was shown before. So this is a cross-sectional illustration of the double hump sign in plateau syndrome. Notice how the ciliary body is rotated anteriorly, such that when pressure is exerted on the cornea, the iris is depressed on the space with pointed in blue, but not the iris overlying the ciliary body in red, and the lens pointed in red. So such configuration can only be appreciated on indentation gonioscopy. And if this is missed, some patients might get a diagnosis of primary angle closure. So it should be noted that in plateau iris, the examiner will sometimes notice that they will have a bit more difficulty or need more force to open the angle because the ciliary processes must be displaced posteriorly as well. So some key features of plateau iris include the narrow anterior chamber angles with a relatively flat and normal central anterior chamber depth. So for this patient, this is the description of this is the diagrammatic representation of the angles. Again, it's closed without indentation. With indentation, it opens up to CBB. So you would think that this is probably, you might sometimes think that this is a case of primary angle closure. But once you saw that there was a plateau iris, you're now further considering plateau iris syndrome. So you're trying to rule out plateau iris syndrome. So for a proper diagnosis of plateau iris syndrome, you also want to rule out the possibility of pupillary block. So for most cases, they will still undergo laser iridotomy. And if it's persistent, or if the angles remain to be narrow and occludable and still have this double hump contour, then it's most likely that the patient really has plateau iris syndrome. So treatment now shifts from just having an iridotomy to being supplemented by an argon laser peripheral iridoplasty. Now let's go through some variations in angle appearance. So this is an image of the angle. It's clearly open. You see the ciliary body band, very darkly pigmented. Then there's the white scleral spur. But notice how the PPM has this very red tinge. Here's another red tinged angle. Although you see a red tinge, you don't see any layers. So this is a closed angle. So red tinge can be seen in an open angle. It can also be seen in a closed angle. Blood in the angle can be from reflux of blood into the Schlemm's canal by pressure, sudden decrease in IOP, or elevated episcleral venous pressure. It can even be from old degenerated blood, and sometimes it even appears black. And because of gravity, sometimes it tends to accumulate more in the inferior angles. Blood in the angle can also be caused by fibrosis and synechia, especially if they are from very friable new vessels. Here's another variation. So you see, angles are open, but you see wispy red vessels extending from the CBB, crossing the scleral spur into the trabecular meshwork. So blood vessels in the angle can extend from the iris wall to the angle vertically, arborize, and then dip into the Schlemm's canal. These situations are sometimes associated with transparent sheets of fibrous tissue that you typically won't see, but because of the obstruction of the fibrous tissue, can cause increased intraocular pressure. In iridocyclitis, these membranes are prominent, which in iridocyclitis, these membranes associated with chronic iridocyclitis do not induce synechia or synechial closure, but with less distinct angle structural appearance sometimes. And in heterochromic iridocyclitis, the vessels over the angle wander and are very friable and bleed easily. So this is one of the things that we watch out for when you're performing cataract surgery in a patient with iridocyclitis. There can be hyphema during the surgery. Sometimes the artery can be visible on your angles. So the artery encroaches on the root of the iris sometimes and its juncture with the ciliary body band. Characteristically, only short segments of the artery come into gonioscopic view in this way. And these always have an obviously circumferential direction. So notice how it goes just a bit up, it curves and moves circumferentially and then dips back. Normal circumferential vessels on the ciliary body band never attach anterior to the scleral spur. So this is just a normal variation. Here's another variation in the angle appearance. Sometimes you see foreign bodies in the angle. Technically, this is a foreign body. It's a blob of silicone oil that is seen in the angle. So for this, notice the very highly pigmented angles. Yes, your angles are pigmented, but in this situation, there's very prominent pigmentation. The ciliary body band is very densely pigmented. So is your trabecular meshwork and even your Schwab's line. It's also shown here. So pigments in the angle are pathologic if it's associated with certain findings, like in exfoliation or pseudoexfoliation. The pigmentation is sometimes more coarse and has a salt and pepper appearance. It's also pathologic in situations with pigment dispersion. Increased pigmentation can also be seen in post-op cases and with inflammation of the eye. So here's just another example of a situation where you see highly pigmented angles. If you see highly pigmented angles, you might have to be a bit more cognizant of the other findings. So in this patient, you notice highly pigmented angles, you check the pupil, you see this white fluffy debris in the pupillary margin, along with a Horfra string, and this patient has pseudoexfoliative syndrome. Here's another variation of the angle. So here, notice that it's open. You see the various pigmented layers, the alternating pigmentation. But notice how, I'm not sure if you see it very clearly in the image, through that ciliary body, you can also see a few ciliary processes. And in this image, it's the same thing. You have the different pigmented layers of your angle, but notice how your ciliary body is a bit wider, especially in comparison to the adjacent clock hours. And in this one, you do see some alternations in your pigmentation. You see the trabecular meshwork, but you notice how the scleral spur is very wide. And adjacent to that, you don't really see much of a ciliary body. So there are variations of your angle, especially if they incur traumatic changes. So one is angle recession. In angle recession, there's a tear between the longitudinal and circular muscles of the ciliary body, as you see in the image on the left. And this will present with a widened ciliary body band. So you will see your ciliary body, but it's very wide. It's not as wide. It's wider than any other angles. Or if you want to make sure you want to compare to the other eye, you'll see that it has a wider configuration. Another variation is iridodialysis. This time, the point of trauma or the damage it happens on the iris root. So now you have your iris splitting away from the ciliary body, and because of that, you're able to see some ciliary processes. Here's another example where it's very clearly seen. And another variation is cyclodialysis. This time, the separation happens between the ciliary body and the scleral spur. So though you see a scleral spur, it's very wide. It's wider than usual. And there's widening of the suprachoroidal space. Here's another variation. So here you don't see any alternating layers of pigmentation. You don't see the angle structures. What you do see are these fluffy tan brown debris in the inferior angle. So these can be inflammatory deposits. It can sometimes be associated with hypopion, and these are typically found in the inferior angle. In severe inflammation, deposits can be circumferential as well, not just inferiorly. There can be KPs in the angle that can be gelatinous looking, can be colorless, can be broader or flatter. And sometimes in patients with mild or chronic inflammation with low-grade inflammation, you might not see anything, but in fact, these patients might have KPs and you might mistake it for POWAG. So based on everything that we've known and discussed so far, with so much of the information that we've been able to gather with just gonioscopy, really, gonioscopy is the gold standard in angle assessment because it provides a panoramic and a 360-degree view of the angle. You directly visualize it. You allow for evaluation and indentation to differentiate angle closure as synechal or appositional. Pigmentation can be assessed. Other lesions can be visualized, like neovascularization, points of trauma, foreign bodies. Also very important is that it's very convenient. You can do it under a slit lamp microscope. You only require a gonioscopic lens. You don't even need a microscope. You don't need a huge OR setup for this. And if you are very well trained or you've practiced enough, it can be very quick. It can take under a minute to perform, and there's minimal cost. You only really need your gonioscopic lens. That's your only investment. However, gonioscopy still has its limitations. It is still technically a subjective technique. My finding might vary for somebody depending on our skill level and how we perform the gonioscopy. So there is inter-observer variability. there is still contact required since you're putting this on the patient's eye. And for some, that might be intolerable because you need direct visualization of the angles. You need a clear cornea. So for instances where the cornea is very hazy or opaque, gonioscopy isn't much of any value to you. As previously discussed, you need a bit of practice and skill for you to be able to perform this well. And if I performed incorrectly, indentation can artificially widen that angle. Because of that, it can be prone to misdiagnosis. Because of this, for discussion's sake, so what are the adjuncts? What are alternatives? So I cannot do gonioscopy, or I cannot, or I'm afraid, or I'm not sure I can do it well. What are some of your other options? That's where your diagnostic tools or adjuncts come in. I'll go through a few of them, briefly discuss what they're for, how they work, and what you can see in these readings. First is the scanning peripheral depth analyzer. This is a relatively earlier piece of technology. It uses visible light technology and measures the distance of light from the optical axis to the limbus. It's a non-contact method. So you see the image on the right, it looks like a slit lamp setup. This is an example of what that reading might look like. So you shine a light into the angles or into the limbus, and then based on the reflection, the machine is able to gather information from the reflected light. So here you see bands of different recordings of light, your corneal epithelial margin, your corneal endothelial margin, then your iris surface. And based on this, you're able to derive certain values and computation of values. So you can measure the central corneal thickness, the anterior chamber depth, and the peripheral anterior chamber depth. And these values can be compared with the normative data for you to determine if the angle, if there is suspected angle closure, if there's potential angle closure, or if the angles are normal. One pro is that it's non-contact, so it uses light. It's not putting any lens on the eye. It allows for quantitative measurements, and it's relatively easy to operate. And it's based on comparison of different studies, it's quite reproducible for open angles. But the con is it's not as reproducible for narrow angles. And you don't really have a view below the iris. So if there's a point of interest in your ciliary body or your ciliary processes, you won't really see it with this one. Furthermore, it doesn't tell you if there's any synechia. It only gives you these quantitative values. And because it uses light, it is affected by corneal opacity. There's also a low sensitivity and specificity for screening PACS. Another example of a diagnostic is the Scheimpflug photography or pentacam. It takes cross-sectional images of the anterior chamber and allows you to get values of chamber volume, depth, pupil diameter, and more popularly, corneal characteristics. But it does not visualize the angle recess. So notice here on the image on the right that you have a very good quality of the image of the cornea. You can see it very well. You see the iris. But notice at the angles just adjacent to the limbus, there's not much detail there. What it actually does is, based on the measurements of the cornea and the iris, it extrapolates that, sort of connects those lines. And based on that, it gets values of the depth of the peripheral angle of the angle, checks how many degrees open is that. It's really just an extrapolation. It, however, is able to take multiple scans of different clock hours. So this is what it might look like. Notice again the flare, the glare in the periphery. So again, since it's optical, you don't really need contact for this. It does give you some quantitative values. It's relatively easy to operate, especially for a technician. But it does not allow you to visualize the angle recess with good definition. Again, there's no view below the iris. You won't really detect synechia, and is affected by corneal opacity, and also has a low sensitivity and specificity for screening packs. And then there's the ultrasound biomicroscopy. This uses high-frequency ultrasound for cross-sectional images of angles and ciliary body, even up to 4 to 5 millimeters. It can produce qualitative and quantitative measurements of angle structures. And with newer technology, it now has an immersion and also a contact method. For those who have been unfamiliar with UBM, this is an example of what it looks like on the right. So it looks like your other ultrasound machines. It's black and white. It's you describe it using echogenicity, and this is what it looks like. Again, familiarity with the angles is very important because with good familiarity of the angles, you'll be able to know what to look for in your UBM. So we look for the scleral spur. This is the anatomic landmark. Notice how the scleral spur, it's this white peak at the angle recess. So the scleral spur is used because it's the most consistently found structure in your angles in the UBM. So any structure anterior to that, that would pertain to the area of the trabecular meshwork. Posterior to that, that would be your ciliary body. So notice how with the UBM, you are able to scan the cornea, the angle recess, the ciliary body, the zonules, the sulcus, and even the lens. Here are just a few examples. Image A shows us that the angle is closed. Notice the scleral spur there. And more anterior to it, notice how there's apposition of the peripheral iris to your angles. But there is still this very small sliver of a gap, right? Image on the right has a patient with a mid-dilated pupil. Notice with the mid-dilation, the iris now has a very convex configuration, and because of that, with bunching up of the peripheral iris towards the angles or the gap or the gape, the distance between the trabecular meshwork and the iris has now closed. So this is an example of of what's happening at the angles in an instance of an acute angle closure attack. Here's another example. On the image on the left, you have a patient with, again, closed angles. The SS is noted by the arrow. Notice how there is, again, occlusion or obstruction of the angles anterior of the structures anterior to that. Laser iridotomy was done. So on the image on the right, this is the scan after iridotomy. Notice how, yes, there is an increase in the space between the structures anterior to the scleral spur and the iris, but there is still that very, very narrow angle. And if you notice, the ciliary body is rotated anteriorly. So ciliary body CB is rotated anteriorly, and note the um, very steep angulation of the peripheral iris, how it dips centrally and then moves back up again centrally as you approach the lens equator. So this is an instance of plateau iris. So for this patient, you might want to consider peripheral iridoplasty. Here's another example. On the image on the left, notice that pointed by the white arrow, you have ciliary body, but it's very wide. So compare it to the ciliary bodies that we've seen before. Oh, sorry, the ciliary body bands that we've seen before. This is very open and very wide. So this is an instance of angle recession. On the image on your right, notice that there is this hypoechoic space between the sclera and the ciliary body. This is an instance of cyclodialysis. So because UBM is a very qualitative mode of diagnostic for the angles, there have been attempts to sort of standardize the description. And this is an example of the standardization technique. This is from the Lee 1I study. These are some of the parameters that have been used to describe it. So the first parameter is overall iris thickness. This takes into account your the peripheral iris and your central iris. It can either be thin, medium, or thick. Then there's also a description of your basal iris thickness, meaning the more peripheral iris thickness. It can be thin, medium, or thick again. Another parameter is iris convexity. If it's just super flat, then it's absent. If it bows anteriorly, it can be mild, and as it gets more convex, it can be moderate or extreme. So these are the reference photos. You can refer to these photos to describe your findings. Another parameter is iris insertion. So this refers to where your peripheral iris inserts in your ciliary body. Is it very basal or is it closer to the ciliary process? Is it more apical? Another parameter is the angulation of the iris. This describes how your peripheral iris inserts to your ciliary body, or the degree or the steepness at which it inserts into your into your ciliary body. So notice how parang mas matarik, no? So none, it's just relatively flat. For mild, there's a bit of a dip. For pronounced, it's like a very steep cliff and a steep drop off. Another parameter is the ciliary body size, wherein you're able to describe the size of the ciliary process. So you have small, medium, and large, and this is always in reference to your peripheral, the thickness of your peripheral cornea. Finally, there is your ciliary body orientation. So you have two, it's just neutral or anterior. It's neutral if it points a bit flat or sometimes even more posteriorly. But when your ciliary process is pointing more anteriorly, that is the anterior ciliary body orientation. There are also attempts to get quantitative values based on these findings. So these are some, there are quite a lot. I'm only going to focus on a few. So this is the Pavlin's measurement parameters here. The most commonly used is the AOD, shown in red. So the AOD, or the angle opening distance, is defined as the length of the line drawn from the point of the of the corneal endothelial surface, 500 micrometers anterior to the scleral spur, to the iris surface perpendicular to the corneal endothelial surface. So that's the line in red. Another parameter commonly measured is the trabecular iris angle, encircled in red. It's the angle formed by the apex of the iris recess and the arms passing through the point on the meshwork 500 micrometers from the scleral spur and the point on the iris perpendicularly opposite. So there, that's that angle. There are various computations that you can derive from UBM, but those are just some of the prominent ones. But sometimes these values can have its limitations. So here's one example. Notice how on the image above, on image A and image B, the values of AOD and the TIA are the same. But notice variations in your angulation of the peripheral iris and in your ciliary processes. So I guess the point I'm trying to make here is that with your UBM, yes, you can derive values from it, but it's only really as powerful as the context or the other findings that are associated with it. So the more information that you're able to compute and gather from the UBM, the better you're able to interpret it. You can also get the angle recess area. So if linear values are not enough, there are certain computations that get area. So again, this shows us that the more robust the information, the more descriptive it gets. So what are the pros? With the new technology, you can now have an immersion method where the patient's eyes under like a water bath. Now you have another method, the contact method, where you have a probe that has a water bath, a sealed water bath attached to it. So it's not as tedious or as messy or as wet of a test. And because of this contact probe, you can now perform indentation and dynamics on the eye. There's also good definition for up to 25 micrometers. It allows view posterior to the iris, and you get quantitative and qualitative values. A downside is that it requires high skill for the operator. It takes a lot of practice and experience, and it can be very time consuming because you are looking at cross sections of the eye. So you're checking all the quadrants with axial views, longitudinal views, and transverse views to get more robust information. And that takes anywhere from 10 to 45 minutes. There's low inter-observer reproducibility because of the operator-dependent nature of the procedure, and it can overestimate PACS. So what are the indications for use for UBM? You can use UBM for instances of opaque cornea because you're using sound waves, not light. You can visualize past any opacity. You can use it for examination in the operating room, and at least for me, it's very important that you can see past the iris. So for instances of plateau iris, if you want to see ciliary body masses, effusional membranes, lens subluxations or tumor, and even intrableb examination. So if you have a failing bleb, you suspect that there are membranes in your bleb. This can be an indication for checking if your bleb has any membranes. So here's just an example. If you look at longitudinal 9, that's the fourth image. Notice again, this is an instance of plateau iris. Note the double hump configuration, the anteriorly rotated ciliary process, and the angle closure. Here's an example of how the UBM can be used to image the ciliary body. Notice the arrow pointed at this the hyperechoic band in the ciliary body. Those are those are membranes indicative of pars planitis. And then notice how the angles are also already closed. So this is actually a patient that has secondary angle closure from chronic uveitis. Here's just another more extreme case of that. Notice how the angles are synically closed. In fact, the peripheral iris is already concave. And then, again, there are membranes adjacent to your ciliary body. Here's an example of the ciliary body and the iris having infiltration from a patient with leukemia. So the patient had infiltration already in the ciliary body. So now you have this heterogeneous hyperechoic densities in your iris and your ciliary body. And here's an example of an instance where there's angle closure. We wanted to evaluate if there was any masses past the iris, and true enough, there was this well-delineated hypoechoic space with largest diameter measuring 2.9 millimeter. So here's an example of a very, very large iris cyst. Finally, we have the anterior segment OCT. This one uses low coherence interferometry to obtain cross-sectional images of the anterior chamber. It's good because relatively it's preferred for some patients because it's non-contact, it's not so invasive, it's not as user-dependent, and it has very many configurations. So through time, we've had different configurations of this. You have the time domain, the spectral domain, and the swept source. Some of you might be familiar with some of these machines. There's the Heidelberg, there's the Spectralis. The difference in these three machines lie in their central wavelength, with the spectral domain OCT having a shorter wavelength or a higher frequency, which gives it a bit of a better HL resolution. But as a trade-off, the depth isn't as well. It can only image up to 2 to 3 millimeters in depth. This is also able to measure a lot of values similar to how it would measure in the UBM. So it can also get angle opening distance, angle recess area, trabecular iris space, can even measure your lens vault, anterior chamber volume. All of these values can be derived from your OCT. So here's an example of a time domain configuration. Notice how, so this is a relatively good, it's an earlier model, so resolution isn't as good, but you notice how it visualizes the cornea well. It has good visualization of the angles. You're getting values for AOD as well and TISA, but notice how you don't see past the iris. You don't see details of your ciliary processes already. Here's an example of a spectral domain scan. Zooming in, we see that there's better definition, right? So notice that even here, you can already see the patent Schlem's canal. Notice that hypo-reflective area adjacent to the 500 micrometer label. That's your Schlem's canal. So that is adjacent to your trabecular meshwork. So in this case, that means this angle is open. And with the ACA value measurement, it's 20 degrees. AOD is 300, around 300. So even with a narrow angle, the angles are still open. This is the more recent model. This is the swept source OCT, where you see good resolution. Again, you don't really see past the peripheral iris, you don't see the ciliary processes, but it's able to get your lens vault, anterior chamber depth, your anterior chamber volume. and of course get the values for your angle as well. The newer models of receptors like the Casio OCT is able to um sort of collect all the data that it gets and makes it into a 3D image so that you can image or visualize all the angles together. Uh, this is all good, but you all have to identify the scleral spur as a reference landmark for measurements as well. So even with that, there's still an operator-dependent factor to it for us to be able to get the best values from this modality. Incorrect identification of the scleral spur may result in error. So, knowing that, how does OCT compare to gonioscopy? OCT is very popular these days. It's gaining a bit of traction. So, here's a meta-analysis of 23 eligible studies that compared OCT against gonioscopy as a gold standard. So, different studies use different parameters, most commonly AOD, TIA. And they found that iridotrabecular touch definition was the most effective and the most reproducible in correlated with gonioscopy. If they saw a touch with your iridotrabecular contact, it correlates well with gonioscopy. Anterior chamber depth had poor studies and variable results. Anterior chamber angle had variable results because even if you had low, as you saw previously, even if you have like a narrow angle, a 20-degree angle or even less, it does not necessarily mean that the angle is open. It just might be narrow. So the results showed that anterior segment OCT has high sensitivity with a strong negative predictive value to rule out angle closure. And a negative result is very reassuring for these instances. But they noted that it had a very low positive predictive value, less than 50%, meaning that if you had findings in this, it would still necessitate confirmation by gonioscopy. Therefore, when would it be best to use an OCT? Well, consider anterior segment OCT for screening when gonioscopy is unavailable because it's relatively easy to use, can be taught to technicians, and has a high negative predictive value. Of course, this will all depend on weighing the cost and availability of the machine in the specific region or location. And you also should consider the population. Will the population benefit? Is this a high-risk population? But it should not be used alone for confirming angle closure. For patients with findings, it's still good to perform gonioscopy after that because OCT is not able to show all the 360 details. It will not give you dynamic tests or indentation. It sometimes might miss synechia, and you don't even have a view behind the iris, which you might have with a direct patient examination. So it's best to use anterior segment OCT as an adjunct to gonioscopy, identifying cases of angle closure when gonioscopy or UBM is unavailable for patients with a high lens vault, a thick iris, or supraciliary fluid. Some physicians will prefer to have an OCT done just as well so that they can educate their patients and that the patients have some form of a reference so that they can visually understand what's going on with their angles and what the doctor is trying to describe to them. And of course, when contact procedures like gonioscopy is not tolerated, then maybe they might be able to tolerate anterior segment OCT. So the pros are there are objective measurements, you get a lot. It's non-contact, it's relatively comfortable. It gets a snapshot of the entire anterior chamber in one scan. It requires less expertise if you want to teach a technician or have it done remotely in a lab and a testing facility or a screening center, it's possible. However, it's only a cross-sectional view. It's quite impractical if you want to see 360, like all the sectors. It cannot assess features other than the angle width. You cannot perform indentation, and there is still measurement variability. So it's just a very broad side-by-side of gonioscopy, anterior segment OCT, and UBM. So if comfort is just the concern, then anterior segment OCT is a non-contact procedure, then medyo lamang siya doon. For instances where there's opaque cornea, UBM has a leg up. But gonioscopy and UBM has the added benefit of you being able to perform indentation. Anterior segment OCT, you don't need a lot of skill to be able to perform this, and it has very good resolution compared to UBM. The information on the anterior chamber, I highlighted all in yellow because each of these have their own strengths and weaknesses. Of course, gonioscopy has that benefit of you being able to actually view the angles. But anterior segment OCT and UBM allows you to get some objective measurements. The major pro for UBM is that you can visualize past the iris. Gonioscopy can be done very fast, specifically if you're very used to it, less than a minute, you can finish it. The widest field of view will be your gonioscopy. With just one mirror, you're able to see so many clock hours already. And just with acquiring your materials, gonioscopy is the cheapest. So weighing all their relative pros to each other, here we see that gonioscopy clearly has all the benefits, right? I mean, most of the benefits, not all. You have the benefit of having a wide angle. You have direct visualization. It's fast. It's relatively cheap, and it gives you the most accurate information. So, in summary, knowledge of the anatomic landmarks and adjacent angle structures is essential in the evaluation of the angle. Using a 3-mirror Goldman gonioscope is an easy method for evaluation, but does not allow indentation. Indentation with a 4-mirror Posner lens is more difficult, but it provides more information through indentation. In angle closure, indentation is necessary to differentiate appositional for synechial closure. Certain gonioscopic findings are indicative of certain diagnoses. Open angle configurations have variations which point to certain diagnosis and hence treatment. Gonioscopy remains the clinical gold standard in evaluating the angle, and various diagnostic exams are available to complement and support the treatment and monitoring of angle closure. And we should consider these diagnostic exams when gonioscopy is not feasible or if you need an adjunct. Consider these when you're specifically looking for quantitative findings or structures invisible by gonioscopy. So with that, I'd like to thank everyone again for joining PAO and the PGS for this session. Again, we are celebrating the World Glaucoma Week, so it's a pleasure to have this session held during this week. I hope everybody takes the time to spread the word. This is not just a concern for glaucoma specialists, it's a concern for all us ophthalmologists. So hopefully we advise our patients and help them gain awareness regarding this condition. And I'd also take this time to announce and promote the upcoming 7th Asia Pacific Glaucoma Congress that will be held at the Philippines in Manila from May 24 to 26, 2024, not this year, next year, May 24 to 26. For more details, you can check out apgccongress.org. So these are my references. Thank you, and we'll be taking your questions right after we hear from our reactor tonight. Thank you.